All right, welcome back. We left off with periodontal instruments, and here we're looking at a periodontal explorer that is able to reach into that focus and feel for any furcation involvements or any debris that was left during or after the scaling and root planing has been completed. So scalers are something that you'll see and hear used in hygiene a lot for periodontal cleanings. Sickle scalers are used primarily to remove large deposits of supragingival calculus. So scalers have an A and supra has an A. So try to remember that. Scalers are used above the gum line, supragingivally. Chisel scalers are used to remove supragingival calculus from the contact area of anterior teeth. They have a flat end just like a wood chisel, and they're used on the flat edges of the lingual, typically of the anterior teeth, most likely the mandibular teeth. The blade on the chisel scaler is curved slightly to adapt to the tooth surface. And then we have a scaler that looks like a hoe that's used to remove heavy calculus that is also supragingival. Hoes are most effective when used on the buccal and lingual surfaces of posterior teeth. Curettes, though, are used to remove subgingival calculus. So curettes have a U and sub have a U. So make sure that you kind of keep that in mind. So curettes are used subgingivally. They're used to smooth the root surfaces for root planing and then to remove diseased soft tissue lining of the periodontal pocket of the soft. This is called soft tissue curettage. So they do many different functions by removing calculus and also the diseased soft tissue. A curette has a rounded end, unlike a scaler, which has a pointed end. So a curette is curved, a scaler is sharp. So keep those two distinctions in mind as well. There are two basic designs of a curette. One is a universal, and the other is a Gracie curette. So here's a look at some double-ended curettes, and we just have this nice rounded tip, and we'll see a little closer picture here in a second. Here we go. So the curette has this curved working end, and sometimes they will have, depending on the type, if it's a universal or a Gracie, the cutting edges on both sides of the blades, or if it's just on the one side of the blade. Here is what a scaler looks like. You can see the very sharp, pointy tip of the scaler. So scaler is sharp, curette is curved, curette goes subgingival, scaler goes above the gingival tissue. The universal curettes are designed so that one instrument can be used on all tooth surfaces. So in these instances, there are two cutting edges, one on each side of the blade. The universal curette resembles a spoon excavator used in restorative dentistry, which you're all familiar with. A Gracie curette has only one cutting edge and is an area-specific end. This means that they are designed for use on specific tooth surfaces, either the mesial or the distal. And the treatment of the entire dentition requires the use of several curettes. So if any of you remember working with your hygienist during our on-campus clinic, they would use a 1-2 in the anterior, an 11-12 kind of in the middle of the arch, and a 13-14 in the more posterior areas. So the higher the number, the more curved or the larger the angle that is going to be present in the shank of the curette. So here is another look at a curette. So you can see that here's the handle coming into the whole working end. And this angle is going to determine the number series of the curette. So again, in this instance, we have a universal curette. So we have the cutting edge on both sides of the instrument. And here we can see, again, the 5, 6, 7, 8, 11, 12, and 13, 14. So most of the hygienists in this area are going to use a 1-2, which is a straight Gracie Curette, an 11-12, and a 13-14. So if we were looking at these actually on their edge, you would see a much more defined curve in that shank than you see here on the 11-12. And that is how you're going to be able to just pick it up off the tray and say, I know that this is the 11-12 or this one is a 13-14 based on that bend in the shank. Surgical knives are some instruments that are used in periodontal treatment. So a Kirkland knife is one of the most commonly used periodontal knife. It usually is double-ended and the blades are kidney-shaped. So Kirkland knives have a kidney-shaped blade. The Orban knife is used to remove tissue from the interdental areas, and the ends are shaped like spears and has cutting edges on both sides of its blade. Another instrument is called a periotome, and these are used to cut the periodontal ligaments for atraumatic tooth extractions. These are thin, sharp blades that cause minimal damage to the periodontal ligaments and surrounding alveolar bone. So here we have the gingivectomy knives. A is showing you a Kirkland knife. Notice those kidney-shaped blades on each end, and then B is the Orban knife with the spear-shaped blades to cut that interdental tissue. Pocket markers are similar in appearance to cotton pliers. However, one tip is smooth and straight, and the other is sharp and bent at a right angle. The smooth tip of the pocket marker is inserted at the base of the pocket, so into the sulcus, and when the instrument is pressed together, that sharp tip makes a small perforation into the gingiva. These perforations, which are referred to as bleeding points, are used to outline the area for an incision on the gingiva during a gingivectomy. So here is a look at a pocket marker. You can see the smooth tip, and then we see this little edge that can pierce into the tissue. So the smooth edge is inserted into the sulcus, and then the operator squeezes it together and forms this little poke hole into the tissue. And once these are created, they make these little bleeding points, and the operator is used to kind of have this as a dot to dot to connect these dots with a line to remove that diseased tissue. An ultrasonic scaler allows for rapid calculus removal and reduces hand fatigue for the operator, typically a hygienist, by converting very high frequency sound waves into a mechanical energy in the form of rapid vibrations. The calculus is removed from the tooth surface. This instrument also uses a spray of water at the tip, which prevents the buildup of heat and promotes a continuous flushing of the debris and bacteria from the base of the pocket. But remember, because of the spray of the water at the tip, there is a large amount of potentially contaminated aerosol spray. And at this time in history, we need to be very aware of the contaminants that this produces. So you would have to use an HVE to capture the mist, the aerosol that is created while using one of these ultrasonic scalers if you're assisting for that procedure. Here are some looks at different shapes of ultrasonic tips. These can come in universal or mesial distal shapes as well. Some of them are thinner, some are thicker than others, so this really is going to depend on the hygienist or the periodontist preference as to which tip they will require to be purchased for the office. Here is a look at an ultrasonic being used. So it goes into the handpiece, and then they just take it and kind of wave it up and under the sulcus, and here is all of that aerosol that's being created during its use. So indications for the ultrasonic is to remove supragingival calculus and difficult extrinsic stains. So those are the stains that can be removed from the outside of the tooth. Also removal of subgingival calculus, which is attached plaque and other endotoxins from the root surface. They are used to clean furcation areas. They're used to remove deposits before periodontal surgery. They can also be used to remove orthodontic cements, and once the brackets are no longer needed for debonding, and the removal of overhanging margins of restorations and certain cements from crowns that are placed. contraindications to use of the ultrasonic scaler. That means do not use an ultrasonic scaler if the patient has a communicable disease. So certainly a patient with a known communicable disease that can be transmitted by aerosols such as tuberculosis or COVID-19 poses a risk to the operator. Any patient who is immunocompromised, so these patients are open to infection and have trouble fighting off those infections. Patients with respiratory problems, because materials can be then aspirated into their lungs, with a patient with respiratory problems making that recovery very difficult. Patients that have difficulty swallowing, they're going to be having a lot of water introduced in their mouth. So patients that have problems with swallowing or severe gag reflexes should not have an ultrasonic scaler. Also, patients who have a pacemaker, we need to consult with their cardiologist to make sure that the ultrasonic vibrations are not going to interfere with the ability of the pacemaker to do its job. Oral conditions that contraindicate the use is demineralized areas. So ultrasonic can remove areas of remineralization that begin to cover the demineralization that has progressed. So we need to be careful of those areas if using an ultrasonic. Any exposed dentinal surfaces, so tooth structure can be removed, resulting in tooth sensitivity. With this ultrasonic, some restorative materials can be damaged by the ultrasonic vibration. If our patients have titanium implant abutments, unless a special plastic sheath is used to cover the tip, the ultrasonic will damage and scratch the titanium, allowing plaque and calculus to adhere to the surface. And if a patient has narrow periodontal pockets, the tip will not fit into the subgingival pockets, and it's not necessary to use the ultrasonic for patients that have healthy gingiva and healthy tooth structure. All right, precautions for children when using the ultrasonic. Young tissues are very sensitive to ultrasonic vibrations. And these vibrations and heat may damage the pulp because, remember, the pulp is very wide and the enamel is very thin on primary teeth, which can really damage the children's teeth. So here's a few more objectives for the next part of our lecture, so you can stop the video and read through those. And we're getting into the non-surgical periodontal treatment. And dental prophylaxis is a very common form of perio treatment. Prophylaxis is the complete removal of calculus, soft deposits, plaque, and stain from all supragingival and unattached subgingival tooth surfaces. This part is highlighted and bolded and italicized because it's important for you to remember that the dentist and dental hygienist are the only members of the dental health care team who are licensed to perform a prophylaxis. You, as a dental assistant, can do a coronal polish, but you are not allowed to remove hard deposits from tooth structure. Prophylaxis is indicated for patients with healthy gingiva as a preventive measure and is the most commonly performed during a recall appointment for the patient. Dental prophylaxis is also the primary treatment for gingivitis. Scaling and root planing are done as a part of the periodontal debridement. So we're removing deposits on the tooth and reducing the bioburden within the pocket. So all of that plaque and bacteria need to be removed. In some cases, gingival curettage, which is a non-surgical technique, may also be indicated for our patients. And a local anesthetic is usually administered before these procedures because they do go into the soft tissue and can be fairly invasive. They're also used to smooth the root surfaces. We need to remember that smooth root surfaces are easier for the patient to keep clean.